This is Chapter 29, The Child with Musculoskeletal or Articulation Dysfunction, Part 3. And we're looking at different casts here. Long leg cast, short leg cast, bilateral long leg cast. This one happens to have a bar between it. A spica cast means it goes over the hips, so you can't bend at the hips. It can be one leg or both. And then short and long arm cast. Most often when there's a fracture, you want to immobilize the joint both below and above the fracture, so something in the hand or kind of low down on the wrist. If it's higher up in the forearm, we probably want to immobilize both the wrist and the elbow. And this is a spica cast that also matches her doll. And when you have a child in a cast, particularly that spica cast where they can't bend, you got to think about things like a special car seat that they'll fit in. And if you notice the girl before, she was in a wheelchair, but it had a reclining back because she can't bend. Little kids, toddlers like this child, get really used to a cast quickly, and they start to think of it as being part of them, and they're very frightened when you take it off because they feel like it's become part of them. So moving on to traction. Traction, I think one of the most frequent times to see it is in a femur fracture. When a child is in a car accident or is hit by a car, they often will fracture their femur, and that muscles around there, that quadriceps is a big strong muscle. It will pull that bone out of alignment, and so we've got to get it back into alignment. So we use traction. Traction is three parts: the weights that pull, the counter traction, which is the body weight that's kind of pulling the other way, and then friction, so that the child doesn't just slide down to the end of the bed from the weight. So we've got to make sure there's enough friction there, and if need be, we can add like a posy to hold them in place. And there's three purposes to traction. The first is to fatigue those muscles. We don't want those big strong muscles pulling those bones out of alignment or spasming. Spasms are really painful, so we want to fatigue them to the point that they don't work anymore and they don't do those muscle spasms to pull the bones out of alignment or to just hurt. We use it to get the bones back into alignment, get them positioned properly, and then to immobilize the joints and that bone. So we're going to pull on one way with the traction, pull the other way with the counter traction, which is probably just the child's weight, right? And to get these to line up. So types of traction. Manual traction's usually should be done by a physician, and that is grabbing the two ends of the bone and pulling them apart to get them lined up correctly. And sometimes they'll do that before applying a cast. Skin means we're using something like ACE wrap around the skin to get that pull with the weights. Skeletal, we're putting pins into the bone to hook them up to those weights in order to pull. On my exam, I will not ask you about the different types of traction, but here's a number of different pictures. So this is skin traction. We have ACE wraps holding these legs in place that then come and hook to the weights that are pulling. The physician will order how much weight. Our job is to make sure that it's right, that it's there. If we have to take this child down to x-ray or something, we don't want these weights swinging, right? Because they're going to get loose and tighter and looser. So we want to keep them steady all the time, but we don't want to ever release them. So you just kind of hang on to the string up here without making it lighter, just kind of holding it so that it doesn't swing if you have to move the child. Here's another skin traction. So again, wrapped with an ACE wrap and then pulling, and the weights this one are down lower. And again, the weights are pulling, and this time that we're kind of supporting some of the weight with this other sling here, and then pulling from the end of the bone with that. And this would be our skeletal traction. So it's actually pinned into the distal femur here. This is a femur fracture. We've got 90 degrees at the hip, 90 degrees at the knee that are pulling this femur into place, and this is kind of a sling holding the lower leg up there to keep this angle right. And again, we want to make sure that the weights are correct, that they're not swinging, but they're also never released. So Alizarov, this is for limb lengthening. So it's an external fixator made up of wings, wires, rings, and then rods. They go in and kind of nick the bone, make these percutaneous ostomies, little cuts in the bone, and then as you pull on it, where those cuts are, the bone grows as it's trying to, fill in those cuts. We can get a bone to grow about 1 centimeter a month to a maximum of about 15 centimeters, that's about 6 inches. That's quite a bit different. We usually are going to have this child walking on crutches, although the couple of times I've seen this, they were not. They run around and are doing all sorts of things with this leg. So these are external rings around, and then these rods go in between and have pins that go into the bone. And we said that bone in there, they've made little cuts in it. And so every day the physician will, or whatever they're doing, usually it's pretty frequently, like daily, they'll turn these, maybe it's a quarter of a turn or something, and so they're keeping this constant pressure, pulling on the bone, pulling on it, and because they've made those little cuts, as it's making new bone to fill in those cuts they made, and that pressure's pulling on it, it's actually making it longer. So things that are not on my exam, because they're on your med-surg exam, cervical traction, amputation, septic arthritis, skeletal tuberculosis, and lupus. So we're going to move on to developmental dysplasia of the hip. They used to call this congenital hip dislocation, but not everyone is fully dislocated, so that's why we call it dysplasia now. So it's misplaced, but not necessarily fully dislocated. So this means the hip is not where it should be at birth. So some prenatal things that contribute to that, those maternal hormones that loosen up the mother's joints, loosen up the fetal joints as well. And then if we have that baby positioned funny, it can cause that hip to not be in place. Our most common presentation of this is a firstborn female breech. Firstborn, that uterus is tighter than in subsequent birth or pregnancies. Breech, they're turned wrong, so the pressure is pushing on the wrong places on the baby. And female, the shape of the female pelvis, they're just more prone to it. So that's the most common child who we have this developmental dysplasia of the hip. If you have multiple births, multiple fetuses, or problems with your amniotic fluid or large gestational size, all those things also are contributing factors. And then this runs in families. My husband's family actually has a lot of dysplasia of the hip. His mother, there were 5 girls, 2 of them had the dislocated hip, one being the oldest, and then another one later down. And of his cousins, from those 5 women, there are 2 female cousins who had it. Both were firstborn female breech. So it does tend to run in families. So our treatment for it depends on the age that it's noted. The earlier the better. The earlier it's noticed, the less invasive the treatment, and the better the outcome. If it's not noticed until a child's, not crawling or having, when they roll, it's different one side to the other, and the parents are, they finally realize there's something going on mobility-wise here. It's a little more invasive to treat and may not be as good of an outcome. If the child is several years old before they really figure out what's going on, it's going to require surgery, and they will probably always have at least a limp. If not, it may stay dislocated. So here's what our normal hip should be. In utero, this is not quite resting in there where it should be, which means the whole hip joint doesn't quite develop the way it should. Right here it comes around, here it should come around here, and instead it goes up. But if we catch this right after birth, get that positioned where it should be as that baby's growing, everything's going to develop normal and it's going to be fine. This one's a little farther out of place, so we've got this tendon kind of stretched out as well, and again we've stopped this joint from really forming the way it should. But if we get this into place, it's going to be okay. And then this one is fully dislocated, and again, if we position it right, there's a lot of growth left if we find it before 6 months, and so we can usually get a pretty good repair with using a harness. So what are we looking for on this? Well, if that hip is not where it should be, we're going to get abnormal or different skin folds. The gluteal folds here are different from one leg to the other. The range of motion of the two hips is not going to be equal, or may not be, or we'll hear a click as it's going in and out of it's dislocating as you run that hip through its full range of motion. Or if we don't catch it till older, we're going to see the child who has their hip dislocated, and they're going to stand very awkwardly because one femur goes into where it should and the other one is way up somewhere outside of the normal joint. So the best treatment is this Pavlik harness, and we want to start this before 6 months. They'll wear it continuously for 6 to 12 weeks. We do want to check their skin underneath it, make sure there's no problems. If that doesn't work, they may move to a spica cast. But here is the harness. So keeping a t-shirt under so we don't get rubbing. This keeps the legs abducted and a little bit anterior. So they're pulled forward just a little, but well abducted. And we usually tell families every day to kind of look and assess the skin underneath there. But that's the harness. And you can hold the baby, you can do all the normal baby care with that on. So congenital clubfoot. This is a child who's born with their feet, usually they're bent in, but their feet positioned abnormally. It can be one or both. They're going to have a real tight tendon on this side and a real loose one on this side. So what we're going to do is serial casting. We're going to take those feet and stretch them as much as we can normally and put a cast on. And then a week later take it off, kind of massage them, stretch them as much as we can, put another cast on, and hopefully in 6 to 10 weeks we've got them pretty much normal. Sometimes if those tendons one stays loose, one stays tight, we may have to do surgery for those tendons, but usually hopefully the casting's all we're going to need to do, and there's a baby with casting on. And then after the casting, we may very well use something like this, where we're keeping those feet, putting them in these sandal-y things with a bar to keep them positioned correctly.